Good afternoon. Thanks very much for the chance to speak here today. So I'm going to talk about what I've made as simple as title as possible, different ways that we've still got to reduce the large number of deaths that there still are from malaria. So just to divide it into three bits, I'm going to talk a bit about pathogenesis of severe malaria, some clinical trials that we've done at Maude, and then finish with some modelling and epidemiology. So it's quite a broad range of topics. And by way of introduction, I understand there's a broad audience, so we'll start very simple. So malaria is a parasitic infection of red blood cells. There's roughly around 500 million cases a year around the world and about 600,000 deaths, although the estimates are quite inaccurate. It's hard to get very good data for that. There are 5 species of the parasite that affect humans. The falciparum causes most of the deaths and causes most of the severe disease, but there's also the other 4. So malaria is widespread across the tropics. So whenever you see a map of malaria, it's always this big band across the centre of the map. And it's particularly high transmission in sub-Saharan Africa, particularly West Africa. But there are a lot of people living in Asia, so there is a significant burden of disease in Asia as well, where we work. So the case fatality rate, so the proportion of people with severe malaria that die, even with very good hospital care, is between 10 and 30%. So if that was a patient of mine in the JR, that's pretty high. That's not many diseases that have 30% mortality. So there are ways that this mortality can still be reduced, and one of them is optimising the way that we use antimalarials around the world. There is potential for adjunctive therapies directly targeting the disease pathogenesis to reduce the mortality. But there are barriers to these potentially good interventions. One is a lack of understanding of the pathogenesis. Despite over 100 years of good research, there's still a lot we don't know about the disease. There aren't good surrogate markers to do intervention studies, so to develop these treatments targeting pathogenesis, it's not clear what we should measure in the trials. And then we now have artemisinin resistance, so there's some resistance to the first-line treatment that we use both for severe disease but also for all disease around the world. So I'll start with the pathogenesis part. This is a picture from our ongoing cohort study in Bangladesh, in Chittagong. So Aryan Dondop started up this study site, and we've got an ongoing series of pathogenesis studies for many years now. And the focus of these studies is trying to develop adjunctive therapies. So this is treatments that are not antimalarials killing parasites, but drugs to target the disease process itself. The problems are that none tried to date are effective. The pathogenesis, as I've mentioned, is limited as how much we understand. To do a trial of an adjunctive therapy, ideally you want to have 2 groups of patients and look at the effect of the drug on mortality. But to do a study like that, you need rather a large cohort of patients. And what's traditionally been done is you start with a small study looking at a surrogate marker to find whether the drug has an effect, and then you move on to a mortality endpoint study later, which requires a lot of funding and a big group to do. So one of the limitations has been there's been a whole series of small surrogate marker studies, but the surrogate markers are not very good. So this is me early on trying to summarise the pathogenesis of severe malaria on one slide. And there's more to it than this, but it gets more and more complex. And there are groups around the world focusing on different parts of this, and if you start to put it together, there is some sort of logic. There will be things we don't know enough about to connect some of the arrows up. It's hard to know where to intervene. It's hard to know how it all fits together. And the crucial thing is, what is the central process that's going on to kill people? What is probably the case is lots of these things are bad to have, and there are different groups of people that have different predominant problems and they die in different ways. So it's a complex, multi-system disease. So in Maude, there's been a lot of focus on this impaired circulation of erythrocytes in very small blood vessels, so especially capillaries. And the malaria sticks in the capillaries and blocks the circulation. So that's been a central focus of the research for some years now. And it's known from histopathology studies, so essentially patients that die, when you look in their brain, they have lots of parasites sequestered in the small blood vessels in the brain, blocking the blood vessels and preventing blood flow. And this seems to be a very common, consistent finding. The more blockage you find, the more severe disease, the higher the chance of death. And the same process happens in other organs throughout the body, and there's lots of new histopathology data coming through that's adding to this weight of evidence. There's been some good historical studies with brain biopsies and also using electron microscopy, looking at the ways that the red cells stick to the blood vessel walls, and there's a whole series of studies being done around the world looking at how that happens and the different mechanisms, and then looking at possible ways to block the adherence of the red cells to the vessel wall. So a lot of work's been done in the systemic circulation. Arian Dondot, my manager at the moment, developed the technique of microscan. So this is looking at this circulation of red cells in the capillaries in the rectum. And there's an advantage of this in that you can access the rectum relatively easy in patients who are very unwell. This technique has traditionally been done in the mouth. It's common for patients with severe malaria to not be able to open their mouth. They get trismus or they have a seizure and they can't open their jaw. So the choice of rectum is more practical for malaria, but you also get this regular network of capillaries with hexagonal shapes that leads itself to analysis a lot more than, for example, the random distribution of blood vessels in the tongue. That's looking at the systemic circulation, but what we're really interested in is what's happening in the brain that's leading to people getting coma, which is the main manifestation of severe malaria. And it's not very well understood what happens because you can't look at the brain of people who are alive very easily. You can't look through the skull, put very simply. So there's not been good techniques to do that. It's like we've been looking around the problem but not at the problem directly. So there's a few things that are thought to happen from post-mortem studies. One is all the sequestration that we've mentioned, the blockage of the blood vessels, but there's also evidence of swelling of the brain, especially in children, and the barrier between the blood vessels and the brain looks to be leaky as well, especially in children. So these processes together leading to coma is what's hypothesized. So what I've been doing is looking at the eye, and the retina at the back of the eye is part of the central nervous system, and it's embryologically very similar to the brain. So it's been called a window to the brain, and it's been used in other studies outside of malaria to look at the circulation in a lot of detail. And what's good about the eye is that the techniques to examine it are very well developed. People with diabetes, for example, have a lot of photography of the back of their eye. There's a lot of techniques for looking in detail in 3 dimensions at the retina, for injecting dye to look at perfusion. So we can use these techniques in malaria. So there's a classical sign of malaria in the back of the eye that a lot of doctors don't know about, but there's a unique set of changes that you can see with an ophthalmoscope. And it's been described for quite some time in children in Africa, and we've been studying the same thing in Bangladesh, in India, and in Malaysia. So we've collaborated closely with the University of Liverpool, who are the pioneers for this technique, and they have a site in Malawi where a lot of the work has been done. So the changes in the eye that we see in malaria are thought to mirror the changes that are seen in the brain. So histopathologically they're very similar, and you get reduced blood flow in both places with a similar pattern. As I've mentioned, the advantage of the eye is you can look at it just with light. You can look straight into the eye where you can't look at the brain. So it's being used as a surrogate to look at changes in the central nervous system in the brain. So this is the retinopathy that we see. So when you look in the back of the eye with an ophthalmoscope, which you've probably had done on opticians, you can also use the same technique with a camera and photograph the eye at high resolution. So the 4 things that we find in malaria, the first one is the most classical and the most specific to malaria, which is whitening. So you get lots of small white spots all over the retina. And you don't see that pattern in many other diseases. And the specific pattern that you see in malaria is unique to malaria. So it's useful diagnostically. You also see hemorrhages, so small bleeding from small blood vessels in the back of the eye. There's a classic type, which is hemorrhages of the white centre. You do see those in other diseases, for example, leukemia, infection in the heart, you can see the same changes. So it's not specific. In the children in Africa, they've seen a lot of white blood vessels. So the blood vessels should be red, with red blood cells inside. But in malaria, we see what they describe as a frosted tree appearance. So if you imagine a tree in the winter time, you get a network of pale blood vessels. And when they do pathology, it looks like they're red cells that have had the hemoglobin eaten away from inside them, which is why they become pale. And then lastly, we see papilledema, which is swelling of the optic nerve head, which typically reflects swelling in the brain. It's usually a bad sign. It's a bad prognostic sign, suggesting a higher risk of death. So that's common in children, and we don't see it very often in adults, as I'll mention. So we have several study sites that have become part of this ongoing study. In Bangladesh, we work in Chittagong, mostly study falciparum malaria, which is most of the burden of disease. We've also got a site in Rukela, where we study falciparum, and in Bikaner, where we study severe vivax. In Malaysia, in collaboration with Nick Anstey's group, we've been looking at severe Null's eye, the same set of signs and similar study design. So this work is ongoing still. It says 2012 there, but they've recruited this year and last year as well. So the aims of these studies are to describe the spectrum of these changes in the back of the eye. So initially as a diagnostic tool. So we're also studying patients with sepsis, with encephalopathy, as in coma, but not malaria, with healthy controls. We've got lots of healthy volunteers, and then comparing the findings in the different types of malaria as well. So when we put together the retinopathy and the disease phenotype, so we measure lots of different things, we observe them either until they get better or until they pass away. We can look at prognosis, so does this retinopathy predict outcome? And then the idea is we can look at the retinopathy develop and improve over time, and it could be a useful surrogate marker for these adjunctive therapy studies. So it's looking promising for that. And then lastly, as I mentioned, we can study in detail the pathogenesis in patients who are alive and changing over time by keeping looking in the eye repeatedly. So the methods we use is a detailed assessment of the patient. We've got lots of doctors that help to recruit, and they assess visual function but also examine the whole patient, take lots of blood samples. We go back to them repeatedly through the admission. We've got a portable camera, which makes a big difference, because traditionally you photograph the eye using a tabletop camera, which you have to sit up and look through a hole. And it's very difficult in an unconscious patient. So we have this portable camera we can use anywhere in the hospital on any patient. So we've developed that camera with a filter very cheaply to do fluorescein angiography, where you inject dye in a peripheral vein and it circulates around and goes into the eye, and then you can photograph in more detail the pattern of perfusion in the back of the eye. So normally you need a very fancy camera for that, but it's just a couple of filters for $50 to adapt it. We've got an ultrasound probe to do high-resolution ultrasound of the optic nerve head. As I mentioned, papilledema being common in children, we can measure it precisely using this ultrasound technique. And we look at the microcirculation elsewhere in the body, so measuring lactate in the blood. So the lactate goes up when perfusion of the organs decreases. We measure the rectal capillary blood flow using the microscan. We measure the stiffness of the red cells. That's another established technique in malaria. So when you get red blood cells that are stiff, they can't get through the capillaries. So it contributes to the obstruction. And then lastly, we measure this protein HRP2, which correlates with the total number of parasites in the body. So that's a good marker, because when you get a lot of parasites sticking in small blood vessels, you don't necessarily see them in the peripheral blood. So you can end up with a low count in the peripheral blood, but actually a lot of parasites in the body. So that's why we use HRP2. And then lastly, we've been using MRI of the brain. So the patients in the last 3 years that have been well enough to go for a scan, we've taken them across the MRI scanner and done a specially designed sequence of MRI scans with a high-resolution scanner. So far we've enrolled 555 people. There's the various groups that I've mentioned. So we've got malaria and also several different control groups to see what's specific to malaria. And we've got different severities of malaria in different species as well. Recruitment is ongoing, so the numbers are increasing all the time. So I'll just talk a bit about falciparum. That's Chittagong Medical College Hospital, where I've been spending 3 months a year for 5 years, where we recruit most of the patients. So it's the intensive care unit, which is quite well equipped, but as you can see in the bottom photo, it's a busy hospital. There are patients lying on the floor there on mattresses, but we get on very well with the local teams, and it's a very good place to do research. So here's an example of a result from Chittagong. So this is widespread retinal whitening, and you'll see there's lots of small white spots all over the place. And that should be uniform orange. There shouldn't be these pale spots, and that's malaria retinopathy. So when you see that with an ophthalmoscope, that's diagnostic. And it's particularly temporally at the side, and you get 2 sets of blood vessels at the top and the bottom that come together, and there's a gap in the middle that isn't very well perfused. And that's probably why we get a lot of the changes in that area. So there's another adult from Chittagong, and they've got the hemorrhages, lots of hemorrhages, and they've also got a few focal white spots. You can see here the pattern is different. It's a similarly severely unwell patient, and the reasons for the differences are one of the focuses of a lot of interest. Here's another adult, again very unwell with severe malaria, and they've just got hemorrhages. They don't have any white spots. So there's clearly different processes going on here. This is a child from Bangladesh, which is very good that we have children as well. We can compare directly with the African children, because there are differences between adults and children anyway. But this child has a similar pattern to what they see in Africa. They've got widespread whitening, they've got occasional hemorrhages. And if you look at that white spot there, so that's a pale spot, which is typical of what we see. Now, when we inject fluorescein dye, you can see that the fluorescein, which is the white bits, isn't getting into that spot. And that's essentially a spot that's not perfused, so the blood is not getting in there to perfuse. And that's a very consistent finding. So the white spots frequently match places that the fluorescein doesn't get in. So essentially those bits are blocked, the blood supply is not getting through. And that's very similar to what happens in the brain. So you can watch that happen dynamically. If you do repeated photos, you can see it develop and get more and more blockage. As they recover, the blockage clears. So this is a patient from India who, on the left side is when they first presented when they went to hospital, and on the right side is 2 months later. So when they first presented, they couldn't see very well. They were colourblind. Their vision was blurry. And then when they came back, it had all gone away. Their vision was back to normal. Then the changes at the top, you can see the whitening on the first image, and then on the right-hand side, the whitening is gone. Then when we inject the fluorescein, where you get whitening, the fluorescein isn't getting through. And there's some leakage down the bottom there, so that's the barrier I was mentioning between the blood vessels in the brain, or here, the blood vessels in the retina. So all of those things have resolved, and that's typically what we see. This is reversible. And whether that's the same process that accounts for the coma in malaria being rapidly reversible, we don't know. But it's again the focus of ongoing study. So here's another adult with again a different pattern of whitening. So they've got lots of small white spots all over the place. When we inject fluorescein, it's a bit hard to see in that image, but they have lots of places where the white spots are that the fluorescein is leaking out of the blood vessels. And that's another common typical pattern that we see. So we're collaborating closely with the University of Edinburgh to analyse the shape of the blood vessels in the back of the eye. It looks like you get distended tortuous blood vessels, which is a common finding in other vascular diseases that affect the eye. So they have a computer algorithm that can measure these things in a semi-automated way, and the results are coming through just now. We're also collaborating with the University of Iowa to analyse the images for the findings of hemorrhage and hopefully whitening as well, so they can put a computer to work on all of the hundreds of images, or thousands of images that we have. And hopefully, eventually we'll have an automated way of detecting the changes, quantifying them and mapping them. So you can imagine how much work it is to look at all of these things individually. We've got something like 50,000 photos now. So it starts with me looking at them, with an expert looking at them, and then hopefully the computer will be trained and good enough to do it into the future. So here's some summary results. If you put together the different groups that we've got so far, the retinal changes, any retinal changes, are much commoner in comatose patients and patients who go on to die. You still see it in patients that aren't comatose, but less severely. And then there are also changes in the other groups, which are known. People know that you get some retinal changes in patients with sepsis. Patients with encephalopathy frequently have the papilledema that we described. However, a lot of those changes are mild and often only in one eye. So when we look at changes in both eyes, most patients with malaria, it's the same in both eyes. When we take out papilledema from the adults, very few of the adults have papilledema. So it ends up being a very specific sign and a very useful sign compared to the other groups. So there's a lot of interest in using this because it's relatively easy to see as a clinical sign at the bedside. So if you look at moderate to severe, so the obvious retinopathy that you can see with an ophthalmoscope, it's 97% specific for malaria as a cause of coma in this group in Bangladesh. So that's useful. And if you look at death, then you're more likely to die if you have retinopathy, and the more severe the retinopathy, the higher the risk of death. And that applies in patients with coma, but in those who don't have coma, that's not the case. So you'd expect that because it's a central nervous system pathology. When we look at lactate, the severity of the whitening, which is probably ischemic whitening, correlates with the level of lactate in the blood. The more stiff your red cells, the more likely you are to get whitening, and the more whitening you get. Look at parasite biomass. The more parasites are on the body, the more retinopathy you get. And when we work out the proportion that are sequestered from the peripheral blood compared to the total biomass, the more sequestration, the more retinopathy. So it would all make sense. When we measure the optic nerve head, what's interesting in adults is we don't see the papilledema. We don't have swelling when you scan the brain, but they have slightly enlarged optic nerve heads. So when we do the ultrasound, it's very sensitive, and there is a difference between malaria and controls, but it's still within the normal range. In children, you see a big difference. So there's a big difference in what's going on in the brains of adults and children. And that's confirmed by the MRI. When we look at MRI in children in Africa, the swelling is often there, it's often prominent, and it's often enough to contribute to death. In adults, we see very mild swelling. A lot of patients don't have much swelling, and it looks like it's an epiphenomenon. It's not related to who dies, who survives. So there's clearly some difference there. So as I said, these studies are ongoing. A lot of what I've just shown isn't published, but it's fine to share at the moment. That's the preliminary analysis. We've got all of the serial photos to analyse. We've got the automated blood vessel analysis. Lots of other things coming. What is hoped is that the retinopathy will be a good outcome marker for clinical trials. So I mentioned some clinical trials that we've done already. So the first, when I first joined Maude, was this trial of N-acetylcysteine in severe malaria. So the theory being that there's a lot of oxidative stress in malaria, so you get oxidative chemicals in the blood that contribute to pathology. And N-acetylcysteine directly combats that. It's an antioxidant. So it was a randomized trial of N-acetylcysteine, measuring, not death, but measuring oxidation in these patients, and also lactate and the clearance of lactate. So again, this is a preliminary study, hoping that the result will be good enough to justify a bigger study looking at mortality. And what's happened, as in a lot of these other studies that have been done before, is that there was no detectable difference between the two groups. So then it's very hard to justify further study, and it stops. So move on to another drug. Whether it's enough patients is hard to say, but that's typically what's happened in malaria. This is another study that happened since, which is directly blocking sequestration using a drug called levamisole, which one of the side effects of levamisole, which is a worm treatment, is to block CD36, or adherence of the parasite to CD36. And that's one of the receptors it sticks to in the systemic circulation. The theory being, if you give it early enough, then the parasites won't stick in the blood vessels and the pathology will be less severe and therefore less likely to die. So again, a small study, not looking at mortality as the endpoint, but measuring the parasites in the peripheral blood. So if it blocks them sticking, they should be visible in the peripheral blood. And we found no difference. And what happened when we did it in uncomplicated malaria first is there was a difference. But at the time they were using quinine, and now we're using our testinate, which is a lot stronger. It clears parasites much more quickly. It's very hard to find a difference in a study like this between two groups. So again, this drug it's very hard to justify doing further trials of it now following this. There's two ongoing studies which I'll mention. One is L-arginine, which is an amino acid that donates nitric oxide when it's metabolized in the body. And nitric oxide causes blood vessels to dilate, which you can imagine would be good if they're blocked and they get bigger, maybe the blood can flow through better. So this is a study looking directly at the blood vessels in patients with severe malaria. Again, a trial, randomized trial. So it's measuring vasodilation peripherally and also measuring lactate in the blood. And then lastly, paracetamol. So this is paracetamol having a side effect of being an antioxidant as well. And it's known to reduce, I have to read this, hemoprotein catalyzed lipid peroxidation, which may prevent renal failure, or at least reduce the amount of renal failure in malaria. And it would be very nice because we use paracetamol routinely anyway. So this is a trial looking at the effect of paracetamol on that. So if it was another reason to use it in severe malaria, then great. It's an ongoing randomized trial. So the other way that we're looking at reducing mortality from malaria is reducing malaria. Sounds simple, but reducing the burden of disease. And also we have all these drugs, but the best way to use them isn't always clear, particularly in the context of drug resistance, which is a growing problem. So my DPhil and my ongoing work is predominantly on mathematical modelling and epidemiology of malaria across Asia. So it's looking at principally the effects of drugs, using lots of different clinical studies and ongoing data collection on epidemiology to try and build a model to predict what's the best strategies for treating malaria. So just a bit of background for those who don't know, but it's focusing principally on the artemisinin, which are now first-line treatment worldwide for malaria. They're the most effective antimalarials. They're very easy to administer, and they've been around for a very long time. It's an ancient Chinese drug that's only recently come into common usage elsewhere in the world. It's known to reduce mortality from severe malaria. There's a big difference between that and quinine, which is why it's taken over for severe malaria. And it's also used as an ACT for first-line treatment, including in the UK, but everywhere. So in 2007, Bill and Melinda Gates announced they were keen to eliminate and eradicate malaria from the world if possible, and they committed to do that, and lots of funds were committed at the time. And there was a big effort that started up that is ongoing, and there were lots of plans made, and lots of countries got involved, and lots of funders got involved. And those efforts are heavily dependent on the ACT drugs, which is artemisinin plus a partner drug, continuing to work. So that's the first-line treatment, trying to reduce the amount of malaria. By treating lots of people, you need the drugs to still work. But then in 2009, artemisinin resistance was found in Western Cambodia. So this is another study of Arjen Dondorp's. It was published in the New England Journal of Medicine, and it was, at the time, a big problem. It was seen as a crisis that needs an urgent solution. Initially, it was just Western Cambodia, but there were a few data from elsewhere. So it was said at the time, if it spreads, it will be a disaster for malaria control and elimination, potentially around the world, if it spreads beyond Cambodia. That was the worry, is that might happen. So it's got potential to severely compromise malaria treatment, not only ACTs, but also severe malaria treatment. And the plan at the time was it was declared an emergency by WHO. Money was found to act urgently, and it was felt that a lot of people should become involved to do something quickly. I was very fortunate in being in Maude at the time, so my PhD ended up being part of this effort. And I was doing modelling, just starting up, and part of the modelling effort to try and guide what to do. The difficulty initially was there were very few data. So we knew the one site in Cambodia. The epidemiology of malaria locally was some information on, but there were lots of gaps in what we knew. We didn't know that much about resistance. And it's very hard to collect a lot of those data quickly to then inform what is done next. So the strategy at the time was to collect data as much as we could and to develop models in parallel. So as well as expert opinion, to use models to guide where we go, and the models would get better as the data come in. So the models have developed to answer specific questions, and the complexity has grown over the years since we started. So it's kind of a continuing cycle. So the questions initially were, how do we get rid of malaria? That was the Bill and Melinda Gates question, but also now that we've got resistance, what are the implications of that? Preventing infections becoming severe was an issue. Is this resistance going to contribute to more severe disease? Are people going to die because of incomplete treatment? How best to treat this severe disease? And as I mentioned, the challenges were lack of data on resistance, a lack of data on epidemiology. So the first model we developed is this, what's been known as the last man standing model. With very few data at the time, it's a relatively simple model, but it gave a helpful answer that if they're going to continue to use ACTs, which is the plan, then that will drive an increase in resistance. And to get rid of resistant malaria, you have to get rid of all malaria, because the resistance is going to keep increasing the more you use ACTs. So it was a driver to have a very strong effort to try and treat as many people as possible, as quickly as possible, to try and reduce it fast. And then subsequent to that, we were at the time collaborating closely with the Cambodian National Malaria Control Programme, and they'd done this study where they managed to reduce the burden of malaria a lot in part of Western Cambodia. And they were very kind in providing the data from that study, which we then used to improve the model, as well as national surveillance data of numbers of cases over time in the same area. So the model I've shown became more sophisticated and was based more on data. We included a few extra parts of the disease following discussion about the first model, and it's been more helpful. But we looked at lots of different strategies, principally mass drug administration to start with, because that's what they've done in this trial. And it showed, as people have since discussed a lot, that mass drug administration is very good, but it only works for a short while. So this is mass drug administration, giving people antimalarials regardless of whether they have malaria or not. So it's giving it to a large population in a short time to try and reduce the amount of disease. So it drops, but as soon as you stop doing it, it just comes back. The other thing we did is we treated a lot more people in the model than were being treated at the time. So everyone got effective antimalarial treatment, and we kept it going. And we found that the effect of that was much greater than the mass drug administration. So to get rid of the malaria, you need to treat lots of people and keep treating, and therefore keep investing, keep spending money over years, and eventually it drops. So we've developed that model to include severe disease and details of the healthcare system and how people get from the community to hospital. And I've used that model to look at particularly Bangladesh, where I've worked a lot with a lot of data on epidemiology and also severe disease, and have some good insights into the system. So I was asked to do this by WHO to look at rectal artesunate, which was becoming a prominent treatment at the time. There'd just been a big trial of it, and they were wanting to roll it out. So it was to look at the cost effectiveness of rectal artesunate. But we've ended up with this model based on the previous ones that now includes a lot more information about the disease and about different strategies to treat. And you can change the type of artemisinin resistance. At the moment, resistance is parasites clearing half as quickly, but you can make that difference, you can make them clear more slowly in the model and then see what difference it makes to outcome. The big question at the time was whether treating everyone with severe malaria with monotherapy, so intravenous and rectal, would cause resistance to spread more quickly. And an outcome from the model is the effect on resistance spreading is very small, because people with severe disease, they either cured or they die, and they don't go on to transmit the resistance. So the contribution of this to the spread of resistance is minimal, which removed a lot of anxieties about further use of monotherapies. And then lately, one that we just submitted is a model of Malaria in Cambodia. So this is using a non-artemisinin combination instead of artemisinins for treatment, which has actually happened in Western Cambodia. And it's looking at different ways to do this, the idea being that it won't promote the spread of artemisinin resistance. But there is a problem in that atovaquone is not the best drug, in the sense that the resistance develops relatively easily to atovaquone. It happens in people on treatment, whereas for artemisinin resistance it looks to happen very rarely, that a new resistance appears and then it spreads. So with this we found that resistance appearing during treatment was a big problem, and that in the population, when you treat lots of people with it, then resistance appears and spreads quickly. And the drug efficacy is lost very quickly, and it's therefore not a good idea to use it on a large scale instead of artemisinins. And the same goes for mass drug administration. Each round of mass drug administration you get an increase in resistance. And they were talking about doing a series of mass drug administrations over a period of time, and each time resistance increases and you lose drug effect. So if you find modelling interesting, we've got a website with a toy model based on some of the models I've presented here, where you can put your own numbers in and run it, and then look to see how much malaria you have in your imaginary population. The plan being to develop this further, and I can put any model into it now. We've got access to the code behind it. So to do the modelling, you need to know a lot about the disease, and as I've said, that's happened in parallel. So to model resistance, you need to know enough of that resistance to put it accurately into a model. And we've started with relatively little data, so the first thing that we have to do is go back to the first study in the New England Journal and look at the raw data, and look at the patterns of parasite clearance. But then, as you can imagine, as part of the efforts to respond to artemisinin resistance, there's an awful lot of other work has happened quickly, so there were other data coming in. So we ended up using data that we could get hold of, putting it together to try and derive enough information to put resistance into a model in an accurate way. So this includes aggregating parasite clearance curves from lots of different patients and trying to get numbers to summarise what the rates of clearance are. So this is an example here. This is Pailin in Western Cambodia, which is the blue curve that's relatively flat. And then there's curves from Thailand and from Bangladesh, from the cohort study that I mentioned that's ongoing. And you can see that the blue curve is a lot flatter than the others, and that's the resistance prolonging clearance half-life in Pailin. It's since been found elsewhere, so it's also now in Vietnam, probably in Myanmar, elsewhere in Cambodia as well, with a similar sort of slow clearance pattern. So with the data that we had, we could put it together and put together different studies and start to derive some information on the effect of different doses of drug, which is important for modelling. And there looks to be very little difference in clearance rate of different doses, and there's since been trials to look at that as well. What was good for me is to put in the intravenous treatment as well, and look at clearance rates with intravenous drug, because that's part of the severe malaria model. And then we have information on phenotype from Bangladesh, so how sick they were, whether they survived or died, and we can look at clearance rates there as well. And we have data from the beginning of our studies in Bangladesh with detailed parasite clearance phenotypes. So that's been aggregated and compared to Thailand and Cambodia, and we're now doing genotyping on those samples. And I'm in the middle of writing it up, but I won't tell you anymore at the moment. So the other part of this is epidemiology, which there's loads of information, and getting accurate information is a challenge, knowing what's right, what isn't right, what to believe, and you get information from different sources. But this has happened gradually since I started doing the modelling. We got good data from Bangladesh, where I work. I know the people that collect it. We trust it. And you can see here the very seasonal pattern of malaria, matching rainfall in Chittagong division. And we can map where the cases are, or at least where they live. And we've got information on their age, gender, etc. So there's a lot of good information there. And then in Cambodia, the malaria control program has been very kind to share their national data, which is very detailed. We've got it by district and sometimes by village. and there's lots of information in there. So I've done this for them, and this has gone back to them as a resource they can use. And just, there's lots of graphs here, but just to show the amount of information that we had. You can see on the left side, that's mostly western Cambodia, and there's been a big drop in malaria in the west. Whereas the top right, those graphs are the northeast of Cambodia, where it hasn't dropped quite so much, and there's still quite a lot of malaria there. And that's now a big question as to why. We've been able to map it over time, so we've got monthly data. Some data sets, it's actually by date. So we've got these maps that have again gone back to CNN. Top we've got falciparum malaria, at the bottom is vivax. And you can do videos where you show every month how many cases there are, and you can divide that by population to get an idea of transmission intensity. And there's information from not only the hospitals and clinics, but also the village malaria workers, which are volunteers in individual villages who people go to for free diagnosis and treatment. And those sets of data match very well, so the trends in both are very similar. So we know how many there are, what coverage they have in which area over time. So just an example here, how they've been rolled out across the time of the study. So it's amazing data that they've collected, and it's very good for developing models. So here, for example, this is the village malaria project. The luminous green line is the, if you imagine that as the proportion of village malaria workers over time. So it shoots up around 2009, and then in the areas where there's lots of village malaria workers, malaria has dropped. And those where there aren't village malaria workers, it hasn't dropped quite so much. The same has happened to mortality. There's a difference in mortality between the two. So they are effective. And then the other information that could be in the National Malaria Control Programme is how many drug treatments have been given out and how many bed nets have been given out. We can put those in as well and then start to tease out the effect of different strategies in real data. So what I'm working on now is looking at transmission hotspots using the village level data. We can do some statistics on what is very fine data over time and work out where the problem areas are, where the transmission isn't dropping quite so much. We've got information on population movement, and I'm currently developing a project to use mobile phone data to look across Southeast Asia, looking at people moving by mobile phone records in collaboration with the School of Public Health at Harvard. So I've been there the last 6 months working closely with them. And we've got information on forest cover, rainfall, etc. So there's potentially a lot we can do. This is all done in close collaboration with the Malaria Control Programme in Cambodia. So just to conclude from that diverse series of studies, so malaria retinopathy, the study of it is contributing new understanding to cerebral malaria pathogenesis, and it's got potential as a surrogate marker for clinical trials. There's a whole long series of adjunctive therapy trials, and now adding to it we've got levamisole and N-acetyl cysteine, which don't have useful effect in severe malaria. Mathematical modelling is helping to guide these efforts to combat resistance and optimal antimalarial treatment, and detailed understanding of the epidemiology and what determines it is crucial to these sort of modelling efforts and to informing control programmes. You can imagine there's loads of people involved, so I won't name them all, but Arian Dundalk, Nick Day and Lisa White are the main people at Maude. Thank you very much.